Okay, I think we'll go ahead and get this session started. So this is the second portion of the morning session. Our speaker is Dr. David Mechanic. He's going to talk on mental health services and policy, the stepchild and healthcare reform. Dr. Mechanic is René Dubos University Professor of Behavioral Sciences and founder and director of the Institute for Health, Healthcare Policy, and Aging Research at Rutgers University. He's the author of more than 400 publications, including The Truth About Healthcare, Why Reform is Not Working in America, Inescapable Decisions, The Imperatives of Health Reform and Mental Health and Social Policy, and Beyond Managed Care. A member of the National Academy of Sciences, the Academy of Arts and Sciences, and the Institute of Medicine, Dr. Mechanic has received numerous awards, including the Rhoda and Bernard Sarnat International Prize in Mental Health from the Institute of Medicine, the Distinguished Career Award for the Practice of Sociology and the Lifetime Contributions Award in Mental Health from the American Sociological Association. The Rima Lapose Award and the first Carol Tobey Award. I'm probably slaughtering some of these names. For distinguished contributions to mental health services research from the American Public Health Association. He received his doctorate in sociology from Stanford University. And I'd like to welcome him to this morning.
Thank you. Good morning. Why isn't this not... Excuse me? Nope. Okay. Thank you. I think... any group who has looked at mental health services in the last 20 years has indicated that our mental health system has been a mess. And while we have, and the most recent being the President Bush's commission, New Freedom Commission on Mental Health, which concluded that our system was fragmented and led to all sorts of costly results because of its poor organization and functioning. And on the other hand, most of these groups that have looked at the system have a very sort of aspirational view of what the system should be. Both of these views were expressed by the Bush Commission. That is, on the one hand, the system was in turmoil. On the other hand, we aspired to something much better and different. But getting there from here is a very difficult challenge. Although increasingly more and more medical care is funded through government, mental health is even more funded through government than general health care services. About 3/5 of mental health care in the United States are funded through various federal programs and federal subsidies. Generally, there are some really major differences in the way in which we do mental health versus the way we do general health care. That has lots of implications now as we are trying to finalize the guidelines, the federal guidelines for the new mental health parity bill that was passed in 2008. And there's some controversy about the details. But to the extent that the systems of delivery are so different, trying to define what parity means in all of its obvious ramifications is quite a difficult task. Generally, we spend about $149 per person for mental health care. Mental health care is different than general medical care in that a much larger proportion is spent on pharmaceuticals as compared with other kinds of services. Mental health care generally has not been growing at the same rate as overall health care. It tends to lag behind in part because it's heavily funded through Medicaid, and Medicaid tends to grow less rapidly than the general private healthcare sector. As you can see in the last line here, between 1996 and 2006, general medical care grew by about 25% in terms of expenditures, but Medicaid expenditures only 1%. Now, the provision of mental health care is very much influenced by insurance, and people with serious mental illness have been less likely to be insured than others in the population. Many of them are not employed and don't have employer-based insurance. And so the uninsured problem has been a major problem within the mental health sector. One of the expectations is as we implement the new health reform legislation, we will be able, through the various provisions of that legislation, to cover more people through the reform legislation. Indeed, also, mental health is much more controlled through managing it from the provision side than from the demand side. In the early 90s, the whole healthcare sector went through a period of managed care, the introduction of managed care in some cases, rather controlling managed care. There was a backlash in the general health sector. Physicians, patients were very unhappy with some of these managed care changes. And as a consequence, in the general health sector, there was sort of a withdrawal or a relief in the extent of managed care controls. However, managed care controls in the mental health sector have continued to be quite strong, and mental health is very strongly managed in comparison to many other kinds of medical services. The other major changes in recent decades is that mental health funding, which traditionally has been quite separate from general health funding, largely it was a state responsibility. States ran large mental hospitals. That has now changed dramatically, with Medicaid taking up a very large proportion of the state contributions. Large mental hospitals have diminished. When I started in this business, we had about 500,000 people in large mental hospitals that were run by states. It's now probably in the vicinity of 50,000. So there's a real change despite the large growth in the population. And now mental health financing is very much integrated into general health care financing, largely through Medicaid and Medicare, as well as through other kinds of insurance programs. Now, there have been, in the case of people with the more serious mental illnesses, many changes in recent decades. As I said, in the early period, throughout most of our history, most of the services for serious mental illness were in state hospitals, run and subsidized fully by the states. They have pretty much largely disappeared, and most care now, even for the most seriously mentally ill, are provided in outpatient settings, and we treat many, many more people, both seriously mentally ill, but also those with more moderate kinds of disorders. When inpatient care takes place, it's largely concentrated in specialized psychiatric, alcohol, and chemical dependency units in general hospitals. Length of stay tends to be rather low as compared with the past. Generally, it's 7 or 8 days, typically, sometimes less in terms of average length of stay for people who are severely mentally ill. As I said earlier, care is substantially financed through federal, state programs, government programs, with Medicaid, a state-federal sharing program, but with subsistence in the community provided through other federal programs like SSI, SSDI, housing programs, food stamps. A wide range of programs, federal programs, help sustain the mentally ill individuals who are living in the community who are no longer in hospitals. Also, the scope of mental health services on the part of mental health authorities have increased to not only cover medical and and prescription kind of care, but also to be concerned with housing, with psychosocial rehabilitation, with supported employment, and a wide range of psychosocial and supportive services. In the last several decades, family organizations have become very powerful and very important and very active in the mental health area. So you have organizations like the National Alliance for the Mentally Ill, which wield a considerable influence and provide a lot of support to families with members who are mentally ill. And that kind of advocacy is quite important and has been very, very powerful. But as I said earlier, pharmaceuticals are the name of the game increasingly in mental health care and account for a growing proportion of services and costs. It grew within the specialty mental health sector from 5.6% of expenditures in 1971 to almost a quarter of mental health expenditures in 2003, and it has continued to increase since then, and increasingly is a higher and higher proportion of all mental health expenditures. We also are treating many more people. We're recognizing many more people as having psychiatric disorders. And in this rather short period from 1996 to 2005, treatment of persons for depression increased from 5.7 million to over 10 million in 2005. For the most part, that is drug treatment. Increasingly, there is less and less psychotherapy being provided. Very often, drugs are now being substituted for counseling and psychotherapy, so that 80% of those treated in 2005 were being treated by antidepressants, and the proportion who are also getting psychotherapy alone or in combination with pharmaceuticals has been increasingly going down. As I said, mental health is heavily managed, and managed care companies have been rationing psychotherapy very substantially. And there's now a lot of concern in the psychiatric sector that there's been too much emphasis on drugs and too little emphasis on the kind of counseling and support and therapy that might contribute to the welfare of patients who are seriously ill, and also for patients who are not so ill, who may not need all those medications, but may do as well or better with proper counseling and psychotherapy. Overall, mental health is now among the 5 most costly chronic conditions in the United States. These are federal data. I've just pulled out 2 in contrast: heart disease and the changes between 1996 and 2006, and mental disorders. As you can see, the expenditures for direct payments of care for mental disorders are now in 2006, over $57 billion. The things I would want to emphasize in this slide is that there are some very, very major differences between mental disorders and heart disease in terms of the distribution of expenditure. There's much more out-of-pocket expenditure in the case of mental disorder because these services are not covered by insurance. Individuals' insurance may not cover mental health services. And until now, there has not been parity in coverage. Coinsurance and deductibles have been higher in mental health care than they have been in general medical care. That is now, as of 2010, that has changed with new federal legislation. The other aspect that's important to recognize is that more people who are mentally ill are treated through the Medicaid program than those in the general health sector. So, for example, approximately 8% of people with heart disease were being treated through the Medicaid program, but almost 18% of people with mental illness were being treated through the Medicaid program. So Medicaid is a very, very central part of mental health treatment in the United States. Generally, if you compare the period, in a sense, we are limited by the big national studies that are done only every several years because they cost many millions of dollars to do. The prevalence of mental disorder in the community has not changed over the 10-year period shown here. About 30% of people have some kind of psychiatric morbidity as measured in these surveys. On the other hand, the amount of treatment provided in this period has increased by more than 50%. In 1990-92, only 2 in 10 people who had disorders were being treated, who had mental disorders were being treated. By 2003 to 2003, it had gone up to about a third. In the general population overall, it had increased from 12% of the population to 20% of the population in the early 2000s. And dramatic increases in the rates of the use of antidepressants, SSRIs in particular, 10% in this particular survey in 2001-2003. If you look at this more specifically, you can see how the treatment of depression in office-based medical practice has changed dramatically. In 1996, about 6 people of every 100 were being treated for depression. By 2005, it was almost double, a little over 10 people per 100 in the population. As hundreds of other studies have shown, women are treated more commonly, more likely to have depression than men, and those increases are reflected here. Generally, the increase among whites is much greater than the increase among blacks and Hispanics, and there's been a major increase in the private sector as compared with the public sector. As I said, the public sector is growing more slowly because of the constraints on tax expenditures and the concern of the states with the Medicaid costs in their budgets. Now, the interesting thing that isn't generally realized is that most psychiatric drugs, or a majority of psychiatric drugs, are prescribed by non-mental health practitioners, largely primary care docs. It's about three-fifths of all psychiatric drugs that are prescribed are being prescribed by primary care docs, and even a larger proportion, about 2/3 almost, for antidepressants and anti-anxiety drugs are being provided by general physicians and not by psychiatrists. Psychiatrists are more likely to be focused in their dominant prescribing on anti-mania drugs, dealing with bipolar depression and so on. And also, they continue to play a very major part in the antipsychotics, although there's been a big increase in general physicians using antipsychotics. That wasn't true 20 years ago. When I used to study physicians 20 years ago, they were quite antsy about using antipsychotics, but increasingly they have felt more comfortable, especially with the new antipsychotics, have felt more comfortable using them. Now, let me just go back. One of the important things to realize is that many of the people who are receiving these drugs do not have a formal disorder. They're psychiatrically distressed, they have psychosocial problems, they have mood variations, but they would not meet clinical indications of disorder. About half of all of the people treated for mental illness do not meet the criterion of a clinical disorder as defined by the Diagnostic and Statistical Manual of the American Psychiatric Association. And many of the patients who are receiving these antidepressants and anti-anxiety drugs do not meet depression or anxiety psychiatric diagnostic thresholds. In fact, if you actually look wide, the major reason for these prescriptions, very often it's not depression as a major indication. It may be back pain, it may be insomnia. These SSRIs are being used for a great variety of complaints. And of course, there's a lot of encouragement of doctors to use these by the pharmaceutical companies, where these drugs have become a very, very major part of pharmaceutical profits. The interesting thing is there's very little evidence that these drugs do any better than a placebo for people who are only mildly or moderately depressed. These drugs seem to have their most important effects for people who are relatively severely depressed, And as I said, the evidence is very weak that there are much use beyond placebo effects for people who have mild depressions. And yet we know they're being used fairly generally for people who have mild depressions, despite the lack of demonstrated efficacy. This comes from a meta-analysis recently in JAMA. The other interesting thing to know about the care-seeking process is that most people with mental illness do not come into care when the illnesses first occur. There's a fantastic time lag between the time symptoms first occur and people make their first contact with the medical care system. As you can see in the second column, generally only a minority will make contact with the medical system in the first year of symptomatology, and the average years that may go by where people may suffer for very long periods of time by disorder are shown in the final column. And as you can see, it varies from anywhere from 5 to 12 years before people are motivated or stimulated to come in and seek care from the general medical sector. So trying to reduce the enormous delay, particularly for people with more severe symptoms, is quite an important challenge. Unfortunately, all of the evidence we have that tries to look at the quality of care for depression, as I said, there's been this fantastic growth in the treatment of depression, but the evidence is, for the most part, much of that treatment is inconsistent or not consistent with practice standards established by professional organizations like the American Psychiatric Association. Generally, in the early 2000s, the estimate was overall that only about a fifth of patients were receiving a minimally adequate care, depression care, in the general health sector. It was about almost 60% were receiving some kind of care, usually a prescription. The treatment was somewhat better in the mental health specialty care among people who were more specialized in treating these conditions, where more than half were receiving adequate, minimally effective care. But in general, the consensus of this and other studies is that the care is very suboptimal and should be much better than it really is. Here's another study done once again in this period 2001-2003 among people who have major depressive episodes, and only about half in this study were receiving either medication or psychotherapy or both, and only a fifth of these patients were concordant with APA guidelines for effective care. You can argue with whether these standards, practice standards, are the right ones or the optimal ones, or are they too stringent. But in general, if you accept expert views from accomplished psychiatrists who develop these standards, generally the feeling is that practice is not meeting these standards or approximating these standards in any adequate way. There is a study, of course, that did find that depression was treated somewhat better. This is a rather famous study done by the Rand Corporation in Los Angeles. It's the largest quality study ever done. It was a massive study looking at quality of care across a very large number of illnesses, major illnesses. I've just picked out two as an example here. Generally, this is a study that found that only about 50% of patients across all areas of care were receiving quality care as measured by the medical experts who provided the standards for this study. In the case of depression, depression was sort of around the average of treatment for all conditions. In this particular analysis, 57% were said to be meeting recommended standards. In other areas of substance abuse treatment and other areas of psychiatric treatment, rates of meeting recommended standards were much lower. They were particularly bad in the treatment of alcohol dependence and substance abuse. And that continues to be a big problem in this area. Okay, the point that's increasingly important to make is more and more general physicians are providing more and more psychiatric care in America, is that for people with severe mental illness, the story has to be much more than just pharmaceuticals. If one is to have a good chronic disease management program with a long-term treatment orientation, there has to be linkage with social and rehabilitative services. One has to be concerned about housing. A lot of these seriously mentally ill people become homeless, and you have to pay attention to whether they do have a place to live and sleep and so on. Medication has to be managed right carefully because a very large proportion of these patients go off their medications. Adherence is a big problem in this population. There's a need for illness and medication education. It's important to involve families to the extent that there are families available and present. Many of these patients are also abusing substances at the same time, so you can't ignore substance abuse treatment. For too many years, the mental health people didn't want to deal with substance abuse, and the substance abuse people didn't want to deal with mental illness. But increasingly, it's the same patients, and one has to have joint programs if one's going to provide adequate care. And there's a real need to develop and get more and more patients into psychosocial rehab. Now, what are the problems? What are the major problems that lead so many groups to conclude that our mental health system's a shamble? Well, a lot of patients don't have access to care, and very often, certainly, they don't have access to specialty mental health care, especially for those who are seriously and persistent mentally ill. Often the care is episodic. There's a real need to provide and coordinate the care in terms of all of these essential elements of care. That is more absent than present. A lot of the care is episodic and acute. As I said, there's a real housing problem for the mentally ill, and if you're going to take care of people who are severely mentally ill, one has to pay attention to their housing issues. We have to do a better job of assuring quality and accountability for quality. There are real problems in community integration and dealing with the stigma. No one really quite knows how to deal with the stigma. It's a real struggle, but that's all part of the difficulty of taking care of these patients. As you probably know, there are many more patients with mental illness in prisons and jails than there are in mental hospitals. Some of them actually engage in serious criminality, and therefore that's not an incorrect placement, but many of them kind of get identified as nuisances and get arrested, or are on the streets and using drugs and get arrested and so on. And many people with serious mental illness who are on the streets end up being jailed and imprisoned, and very often the course of care that follows that is rather poor. There's now a lot of emphasis on trying to improve the process of averting jail and getting people into mental health services, but that's a really difficult and challenging task, and we're not doing very well at it. Also, there's the issue of managing the very difficult and resistant clients. As I said, many of these patients have substance abuse comorbidities, and when patients have substance abuse comorbidities, they have a much worse course. They get into much more difficulty, more likely to be arrested, more likely to become homeless, more likely to get involved in sort of altercations. So that's a really difficult population that has to be dealt with. And as I said, the treatment adherence problem is very, very difficult, particularly for people with schizophrenia and psychotic illness. And there's a real need to provide fairly aggressive management if you're going to keep people on their medications. As I've already indicated, people with serious and persistent mental disorders depend very greatly on the Medicaid program. They're generally poor and have no insurance. frequently, and therefore it's the Medicaid program that is their safety net. The Medicaid program, as you know, is a federal state program, a matching program, and coverage varies greatly by state. Many of the mental health services that are provided in Medicaid are optional services and not mandatory services. So some states provide very minimal mental health care, and other states provide very comprehensive Medicaid mental health care. In the more liberal states in terms of coverage, their coverage tends to be far better than the coverage that's typically available in private health insurance, because it's more of a chronic care coverage dealing with a whole set of services that make up a good chronic care management program, while a lot of general health care insurance is still largely organized around the management of acute illness and not the management of chronic illness. In the late 90s, the federal government funded these efforts around the country to look at different disease areas and make assessments as to how good the care was relative to the then evidence-based practice standards. A lot of the physician groups, particularly the orthopedic surgeons, didn't like the result of these studies and actually ended up lobbying the Congress to, they tried to eliminate the Agency for Healthcare Research and Quality, and weren't successful in doing that. The agency is now revived and is doing pretty well again, but they did get the agency out of the guideline business, and the federal government is no longer setting these guidelines through this evidence-based process. But they did do this for a great variety of conditions, including schizophrenia. And one of the findings that I think is quite important, has been replicated in many other studies, is that while the pharmaceutical treatment of schizophrenia, that is the use of antipsychotic medications, was pretty substantially, was substantial and for the most part was reasonable. There was some problem in terms of prescribing and what was seen as the appropriate dose range, but in general, most patients with schizophrenia were receiving appropriate antipsychotics, and when they were in outpatient care, they were receiving appropriate maintenance care, which is necessary for people with schizophrenia. However, for the most part, when you get to these evidence-based psychosocial services, they were not receiving these. Very few were receiving psychotherapy and counseling, family education and support, vocational rehabilitation. Those continue, from the various studies that are done, continue to find that those services are generally not available to most people with schizophrenia who could benefit from those services. So we're doing better on the medication side in terms of getting more patients appropriate medication, but we're still doing a very lousy job on the chronic care, psychosocial, rehabilitative side. And despite constant lobbying from various organizations on that point, we haven't made too much progress. As I said throughout, basically the mental health sector is one which is dominated by pharmaceutical and pharmaceutical influences. As I said, there's been massive increases in prescriptions of mental health drugs for adults, children, and the elderly. Prescription costs are the largest cost center in state Medicaid programs. These pharmaceuticals are marketed very aggressively by detailing to physicians, direct-to-consumer advertising. The companies try to encourage the definition of new diagnoses for which their drugs can be used and encourage in various ways their off-label use, even though they haven't been recognized by the FDA. They fund, as you know, professional education, professional groups. If you ever go to a meeting of the American Psychiatric Association, they're dominant everywhere. They also fund the consumer advocacy groups. They form alliances with consumer advocacy groups to make sure that drugs are on formularies. They're very, very aggressive and very, very successful. Increasingly, we're learning from a number of studies that unfortunately the scientific literature on pharmaceuticals is distorted and biased. The pharmaceutical companies are doing most of the clinical trials and controlling most of the clinical trials. There's a lot of evidence now that they have been withholding publication of negative results, and they tend to selectively promote studies with positive results and tend to ignore studies with negative results. More recent high-quality studies show that both the efficacy of the SSRIs and the efficacy of the atypical antipsychotics are greatly exaggerated. It turns out that the SSRIs are no more effective than earlier antidepressants, and while they seem to be more benign in terms of side effects, increasingly we're learning that both for those drugs, but even more so for the atypical antipsychotics, there are very serious side effects that are not the same as those from the first-generation antipsychotics, but side effects that lead to metabolic syndrome, diabetes, gigantic weight problems, all sorts of problems. And as you know, there have been several government actions for deceptive advertising and detailing on the part of some drug companies in the marketing of antipsychotics. Here's one study that we published in the New England Journal of Medicine in which they went back to look at the data on various clinical trials filed with the FDA versus the actual published papers on those trials. And they found that 97% of the positive result trials got published, 50% of the questionable results trials got published, and only a third of those which had negative results got published. There also are studies showing that when the trials are funded by pharmaceutical companies, they get better results than when they're funded by other sources of funding. These investigators also looked at the details of the publications when these results were published and found that very typically the publications exaggerated the positive results relative to the FDA assessments of those results. And in general, they found that the effect sizes for the efficacy of those drugs the exaggeration, the bias and effect sizes ranged from 11 to 69% with an average of 32%. The big change in mental health, actually, as you know, the health reform discussion we've had has not really talked much about mental health, but one of the very, very big changes, which is going to be affected by the health reform and the prior legislation, was the passage after many, many decades of effort of the Mental Health Parity Act, the Wellstone-Domenici Mental Health Parity and Addiction Equity Act in 2008. That has gone into effect this year, although the final regulations are still not written. They're still haggling over how one implements the legislative language in terms of its provisions. This act does not require any insurer to cover mental health, but if they cover mental health, they must cover mental health on the same basis as they cover general health care, meaning that they have the same deductibles, co-payments, co-insurance, limitations on treatment, numbers of days of coverage, that kind of thing. The plans, as I said, mental health is very heavily managed compared to general health care, and the plans may continue to manage benefits, but according to these guidelines, according to the bill, they must make mental health substance abuse disorder medical necessity criteria available on request, and those should be no different than, that is, the stringency of those requirements should be no different than those for general medical care. Now, that's a really tough issue because these sectors operate so differently and have such different forms of treatment, so that when you look at the management of care, it is very hard to say what is comparable to surgical care or general medical care, when you're dealing about questions about the treatment of someone with schizophrenia or bipolar disorder and so on. And right now there's the various interests are involved in these guidelines, and we're now awaiting the final guidelines, the opportunity to put in information to the government has just ended, and now they will obviously come up with a new set of guidelines. But the general thrust is that basically there would be no discrimination in the coverage of care in insurance for mental illness as compared with other kinds of illness. And that has to be obviously worked out in the details of the regulations. Now, what it will really change, although mental health reform legislation did not specifically deal with mental illness in any large degree. I mean, there are pieces in the legislation that provide money for autism and for other kinds of disorders, but generally the main thrust of the legislation is not specific to mental health. But by insuring 32 million people who are very low income or have no income, both through an extension of Medicaid and through the exchanges in the general individual insurance market, many more people with mental illness will now be insured and therefore have access to these protections that are available. Mental health parity will be applied in various ways. Medicaid is not an insurance program in the same sense as employer-based insurance, but the government is now extending parity in various ways to the various government programs. So the mentally ill will benefit by the extension of insurance and therefore the protection of parity in the future. We have to see how that plays out. Many states have passed parity bills. Most states actually have their own parity bills, some stronger than the feds, some less strong than the feds. And what we find is that parity does not necessarily make access to services, appropriate services, available. Very often the services are just not there in various localities around the United States. Very quickly, this is a little off the general point, one generally finds that when one looks at mental health disorders, they are related to socioeconomic status. The poor are more likely to have disorders than the more affluent, and people with low income, people with less education are more likely to have these disorders. This is not so true in terms of racial distinctions. On the other hand, people who are less affluent or people who are poor have much less access to medical services, so that, as you can see, the more education people have, the more treatment they have, the more income they have, the more treatment they have. However, so those individuals who have the highest burden of mental illness tend to have the least use of mental health services. There's an inverse relationship between aggregate need and aggregate access to and use of services. And those inequities concern lots of people in the society. So what are the major challenges as we face the future in mental health services? First, there's a need to continue to maintain commitment to mental health services within overall health expenditures. Mental health expenditures have been falling as a proportion of all health expenditures, despite the big emphasis on mental health. It's a little item, I think, this morning in the Wall Street Journal, indicating that the biggest source of hospitalization for veterans in the military is now a mental disorder, PhD and other kinds of disorders of veterans of soldiers who have been exposed to very extreme stresses in their service. As I've already said, mental health and substance abuse services are much more tightly managed than other medical services, and we have to make sure that that management is fair and equitable and consistent with evidence-based standards. There is some evidence from various studies. It's not clear and definitive. It's difficult to do these studies, but that managed care tends to inadequately differentiate among levels of severity and need. One thing about mental health managed care is it's provided more services to more people in the aggregate. But if you look at those who are most sick it's provided less services to those who are less sick. And the issue is whether those are evidence-based decisions or whether those are cost decisions, and how one adequately monitors that and assesses that is an important issue for the future. As I've said throughout, that there is insufficient evidence-based appropriate treatment throughout the mental health sector, and increasingly we have to move toward improving the quality of care, and particularly throughout the whole general health sector, the quality of chronic care, which we know is deficient in many, many ways. And in the mental health sector is inadequately monitored. We spend much less effort evaluating care in the mental health sector than we do in cardiac disease or cancer, and there's a real need for improving the quality of monitoring and evaluation. But I think it's fair to say that the mental health advocates in this country are fairly optimistic. They see impending change both with the mental health parity bill and the new health reforms, which will cover many more people with mental illness than were covered before by insurance. And so while people are carefully optimistic, there is a need to really monitor the process and see what really happens, because as we know, legislation doesn't necessarily, and insurance don't necessarily lead to access and high quality care. Thank you. Be happy to take any questions you might have.
Question. I don't know if this is on. I worked for a time in the state prison system medical program, and it was astounding to me how many people in the prison system had mental illness. And I just kind of wonder if there's been any studies to show with the decline of the big state hospitals, have they just changed the population from the big state hospital to the big state prison? And it's just amazing to me how many people in the prison system are mentally ill.
I think that's true, and in fact, there are some studies of prison population showing that, once again, it depends on what you mean, whether you're looking at any kind of mental disorder or you're looking at the most severe mental disorders, but generally a very large proportion of the prison population in America have either substance abuse disorders or mental illness, and many who are very seriously mentally ill. This is actually a very difficult area because, the mental health advocacy organizations talk about the criminalization of mental illness and argue, and there are many, many more people, as I said earlier, in prisons and in mental hospitals with mental illness. Now, many people who are in prison are in prison for drug abuses, for illegal possession of drugs and so on. That's a rampant problem among the mentally ill. So, basically there are arrests made, possession of drugs, and they end up in jail. And so a lot of them are people who, in a sense, have actually violated the law and go to prison, but they have mental illness and substance abuse. And many people believe they shouldn't be in prison, they should be in mental health programs and being treated for their psychiatric illness and substance abuse problems. Also, there is a problem that a small segment of people with mental illness, with serious mental illness, engage in serious crimes, and they are arrested and convicted and are in prison because of their criminal violations. And so it's important to distinguish between sort of two parts of the prison population, one that's in prison and incidentally also have mental illness but are in prison for serious criminal violations, and then those who are basically in prison because their mental illness leads them to get into situations on the streets where they become nuisance or disturbing and they get arrested and so on. In some localities, it's even said that police make compassionate arrests, feeling that patients are better off in jail than on the streets, homeless, without food, and without services. That's a matter of some dispute. But there's no question that we have an extraordinary problem in mental illness in prisons, and a very large problem in terms of both diversion to avoid prisonization, but also a problem in reentry to the community. The other side of this problem is when people with mental illness in prison get released, they often get dumped back in the community with no services and have a very difficult time accessing appropriate services. And so now there's a big push on the part of state government, the federal government, and advocacy organizations to try and develop reentry programs that help getting patients back into the community in a fashion that they can survive in the community without ending up back in prison and jail. So that's a massive problem. And of course, like many of the sort of underclass individuals who are most deprived, their problems get less attention than the average middle class person, but it is a massive problem. Okay, thank you.